Hello everyone and good evening. My name is Michael Tarr. I'm a third-year medical student from New York Medical College. And before I continue, if you could just direct your attention at your screen in front of you, I'm going to go through a series of 3 polls pretty quickly. And the first poll asks, which profession or role do you represent? So I'd like to welcome back anyone who's participated in the past, who's joining us again tonight. And also welcome anyone who's new. And before I go on, let's see who's joining us tonight. So it's from the people that are joining us tonight. It says that 28% coming from administration, 6% are working in medicine, 6% are in dentistry, and 61 are in other. Wow, that's a lot. All right. I'm going to continue. But the next poll asks, in which stage of your career are you in? All right. So it's my pleasure to welcome you all tonight to the Interprofessional Virtual Grand Rounds presented by the American Academy of Developmental Medicine and Dentistry. So the AADMD Virtual Grand Rounds seek to create a space for mentorship and exchange of knowledge and experience between seasoned IDD providers, entry-level clinicians, and future healthcare providers in training. The purpose of the Grand Round session is to expand and strengthen the IDD healthcare workforce across a spectrum of experience levels. At the end of the presentation, please stay on with us to ask any questions you have for the presenter. Questions can be submitted through the Questions tab on your gray control panel on your screen. So let's go over this next poll. So I said, in which stage of your career are you in? 5% said pre-health profession training, 10% said health professional training, 5% are in the residency, and 80% are currently practicing. All right, we have one more poll. The last poll asks, what do you hope to gain from this webinar? So before I go on, I want you, after you answer the poll, you can look at the Handouts tab on your gray control panel. You can actually download tonight's presentation and follow along with us if you'd like. In addition, I'm going to paste a link to our survey, our post-presentation survey, into the chat box. But you'll also get a copy of it emailed to you tomorrow if you registered with us. And so it's a quick 5-minute survey that's very important to us that you fill out, because the feedback we receive through this survey allows us to improve the virtual Grand Rounds experience and also to hear what future presentations you'd like to have us organize. So I'm going to close this poll. And so it asks, what do you hope to gain from this webinar? 9% said learn foundational healthcare concepts for individuals with IDD. 36% said gain 36% said gain interprofessional perspectives on healthcare for individuals with IDD. And 55% said gain pearls from complex and challenging clinical cases. All right. And next I will introduce our presenter for tonight. Tonight's presenter is Dr. Jodi Tate. Dr. Jodi Tate is a clinical professor at the University of Iowa Hospital in Clinics, and she is the Vice Chair for Clinical Services for the Department of Psychiatry and co-director of the Intellectual Disability Mental Illness Program at UIHC. Dr. Tate received her medical degree from the University of North Dakota and completed her psychiatry residency at the University of Iowa Hospital and Clinics. She has enjoyed providing psychiatry care to adults with intellectual disability for the past 15 years. She is passionate about educating psychiatric residents, medical students, and mental health professionals on how to provide comprehensive care to this population, and has received numerous professional awards recognizing her work with this population. So with that, I will hand the floor over to our presenter, Jodi Tate.
Well, good evening. I'm hoping people can hear me, and I hope that somehow I will find out if people do not hear me. Thank you, Michael, for getting this all set up. I'm impressed by the smoothness of this whole event. And I must say it's a little odd giving a presentation without seeing anybody's responses, so I will do my best just talking to myself. So today I'm going to be talking about challenging behaviors in adults or individuals with intellectual disability. And I should say that I am an adult psychiatrist, and so I work just with adults, and so even though the things I'll talk about, I think, apply to lifespan, but my focus is on adults with intellectual disability. And the next slide just goes through a brief overview of what I'm going to be talking about. I'm just going to give a very, very brief history, which it sounds like pretty much everyone's going to be familiar with, since 80% of you are out in the workforce. A little bit about etiology and epidemiology of ID, and then getting into talking about challenging behavior, which I'm quite passionate about that type of behavior. So just some terms that I might be using. The ID, I think everyone knows that means intellectual disability. PWID, persons with ID. ASD refers to autism spectrum disorder. Dual diagnosis. In this presentation, we'll be referring to mental illness and intellectual disability, and challenging behavior, I will have an abbreviation of CB. So I just wanted to give folks a brief history of how things used to be. I was born in 1969, which I feel like isn't that long ago, but I guess it is getting farther away by the day. But Philip was a baby that was born in 1968, just a year before I was born, and he had Down syndrome. And his parents took him to a specialist, pediatrician who was a specialist in working with folks with ID and Down syndrome, and he told the family that, you know, he's got a great place where Philip can go, and this place has no oxygen, they don't do any operations, and there's no miracle drugs that are prescribed. And that was considered to be a very good thing. The father of this young child, Philip, was a professor and a medical ethicist, and he wrote an opinion piece in the Atlantic Monthly in 1968 that discussed his experience with having a son with Down syndrome. And he said that people have no reason to feel guilty about putting a Down syndrome baby away. True guilt arises only from an offense against a person, and a Downs is not a person. And so that wasn't too long ago, and I think all of us would agree that that's pretty disturbing to hear that now. And things have improved, but we still have a long way to go. As everyone, I think, is aware that this is extremely underserved population. We lack community services, and unfortunately this population has a high rate of mortality and morbidity. And there's lots of reasons for this. And at least in the psychiatry world, there was very little interest or expertise in working with this population, and really it was thought in the psychiatry world that these individuals just don't have a mental illness. There's a significant lack of education and training of healthcare providers. And when I was in medical school residency, I learned nothing. Essentially, you know, Down syndrome is trisomy 21, and that was about it. And there's this phenomenon called diagnostic overshadowing, which I'll talk about a little bit later, that leads to a lot of increased mortality and morbidity. So a little background on epidemiology. ID affects about 1 to 3% of the population. Males are affected more than females, and about 30% have a dual diagnosis, so mental illness and intellectual disability. There's lots of different reports out there on the exact prevalence or incidence of mental illness in this population. There's not huge consistency in that report, but it's generally thought that around 30% do. And about 40% of individuals with autism have an intellectual disability. I'm not really going to talk too much about autism in this talk, but I wanted to share at least one slide that talks about the relationship between autism and ID, and this combination is one of the strongest predictors of psychiatric hospitalization, psychotropic use, and challenging behavior, and we'll talk about that a little bit more. And transition to adulthood is extremely difficult for this population because for a variety of reasons, but a big one is that services essentially drop off when this population moves to adulthood. All right, so next I'm going to get into challenging behavior. And what is challenging behavior? What do I mean by challenging behavior? So it refers to aggression, physical or verbal aggression, property destruction, so throwing chairs, tables, etc., self-interest behavior, non-compliance, like eloping or not taking medications, or essentially non-compliance. Not really going to be talking much about inappropriate sexual behavior. That's a whole nother talk, but sometimes that's considered to be challenging behavior as well. And I think it's important before we talk about more about challenging behavior to really make it clear that challenging behavior does not equal ID. ID does not equal challenging behavior. Only about 25 to 50% of people with ID have challenging behavior. Again, there's lots of different numbers out there, but 25 to 50 is the most consistent. So that means 50 to 75% of individuals without intellectual disability do not have challenging behavior. Individuals that have autism and intellectual disability, there is a higher rate of challenging behavior in that population, but not with people that do not have autism. So that's really important because what happens is in our healthcare system, when somebody with intellectual disability comes in with challenging behavior, I think healthcare providers think, well, they're acting that way because they have intellectual disability, when that is often not true. And challenging behavior, in my mind, is like a fever, and we need to figure out what the underlying cause is. And there's this phenomenon called diagnostic overshadowing, where healthcare professionals say, well, the individual's acting like that because they have ID, and then we overlook underlying psychiatric and medical comorbidity that that goes untreated and results in increased mortality and morbidity. So now I'm going to talk about what does cause challenging behavior, and I'm going to start off with a case that I'll highlight as we're going along, and I've changed details of this case, including the person's name. But this is a patient I've followed for about 10 years. And so he's a 25-year-old male who lives in Iowa City here. He lives in a house with 2 roommates, and he has 24/7 support from a community agency. He has a diagnosis of autism and probably PTSD, and has moderate ID. He has a VP shunt, hydrocephalus, seizure disorder, constipation, and reflux. He has a long history of challenging behavior dating back to age 2, is engaged in physical aggression, property damage, smearing his feces, and has been hospitalized about 4 times because of that behavior. Thinking globally about challenging behavior, as I said earlier, I view challenging behavior as a fever. And you don't just say, if somebody has a really severe fever, well, let's give them Tylenol and call it good. You want to figure out what the cause of that fever is. And that is the same with challenging behavior. And so there's multiple causes. And challenging behavior can be caused from mental illness. Individuals perhaps trying to tell you, hey, I have a mental illness that needs to be diagnosed and treated. Or the person's having side effects from medications, or they have a medical illness, they're constipated or have a urinary tract infection, or perhaps they have a genetic syndrome that has a behavioral phenotype that is associated with aggression or challenging behavior. And the reason why these are all different colors is because generally it's different specialties that sort this stuff out. So as a psychiatrist, I'm primarily trying to figure out if somebody has a mental illness or if they're having side effects from their meds. I think I do a decent job of trying to figure out medical illnesses going on, but that's clearly not my training. So it's important for somebody to see a medicine doc or a dentist or another healthcare professional to figure out if there's underlying medical conditions. And genetic syndromes, often geneticists help us figure that out. So you can see there's already some complications to trying to figure out what is the cause of the underlying challenging behavior, because there's all different specialties involved. And so that's the medical end, where, you know, what my training was, and the way I kind of see the world is through medical lenses. But then there's this whole other side of things, and it's more of the behavioral, or how does the environment influence the development of challenging behavior. So there's all these green bubbles over here where the individuals may be saying that they want something, or they don't want something, or they want somebody to pay attention to me. And these green circles are what psychologists figure out, and through applied behavioral analysis, and I'll talk a little bit more about that, but to try to figure out what the function of the behavior is. So to really figure out the underlying etiology of challenging behavior, you need an interdisciplinary approach and a lot of specialists involved in trying to figure that out. And I feel very strongly that if you don't do this, and if you don't think about all these things, then we can't get it to the bottom of the challenging behavior. And then what happens is we just end up prescribing psychotropic medications that cause more problems. And as a psychiatrist, I can say that, right? Too many psychotropic meds being prescribed. All right, so what I'm going to do now is talk about each of these individually. Not going into a lot of detail, because each one in and of itself is a whole another talk, but I just thought I would highlight each one of these causes. So the mental illness. There's a lot of controversy over this relationship between challenging behavior and mental illness, and what exactly is the relationship. If you look at the literature, there's lots of different thoughts and opinions out there. Some say that challenging behavior equals a mental illness. Some say challenging behavior is absolutely not secondary to a mental illness. And I think the reality is that it's some of both. I think some mental illnesses can present with challenging behavior, and some challenging behavior has nothing to do with the mental illness. So it's not a black or white phenomenon. It's really difficult in psychiatry to make a diagnosis in folks. Well, it's challenging in all populations to really make a diagnosis. As I'm sure most people know, we don't have any blood tests or imaging to help guide our diagnosis. It's based on evaluation and gaining a history. And in this population, sometimes that can be challenging. But one of the most therapeutic things I ever read was talking about clinical uncertainty in medicine, but particularly working with this population, and that clinical uncertainty is ever present, and so is our urge to deny it. So acknowledging the uncertainty and its denial can be therapeutic, not only for the clinician but for the patient, because I think when we get impatient and think that we need to know exactly what's going on, then that results in overprescribing a medication. So realizing that we might not know exactly what's going on is important, and taking our time and making a diagnosis is important. In psychiatry, because we make most of our diagnoses both based on patient report and longitudinal history, when you're taking a history from a patient with ID, it's important to understand that this population often has a desire to please, so it's really important not to ask leading questions and to be suggestive in your questions, because then that can bias your answers. This population has a high rate of self-talk, which often is misinterpreted to be psychosis, and so it's very important to be aware of that. So it's not easy making an accurate psychiatric diagnosis in this population. For those of you who aren't familiar with the psychiatry world, there's a DSM that essentially is the manual where we base our diagnoses from. And there is a DSM that has been created for the ID population. And I apologize for this kind of hazy picture of the DMID, but this is an edition, and it's a great manual that goes over each mental illness and how its criteria is adapted to this population. So if you're not familiar with that, it's worth checking out. So what kind of things do you look for? So in individuals that have mood disorders, it's really important to pay attention to changes in their sleep or their appetite. But in terms of challenging behavior, this can present in terms of, I'm very sorry, my whole family just came home trying to get them to ignore me, so if you hear sounds, that's what it is. People that have mood disorders often have a change in their interest levels. They're not interested in doing things. And so if somebody used to like to go bowling, and now staff are saying, hey, do you go bowling? And they don't want to go bowling, but they have a hard time articulating that or describing that. They may hit somebody or they may throw something, and that the challenging behavior could be because of a mood disorder or depression. If somebody's manic, they may engage in inappropriate behavior, maybe inappropriate sexually, or masturbating more, or taking off their clothes, and that can be described as challenging behavior. People that are psychotic can be aggressive. I have a patient right now who's in the hospital who has schizophrenia, and he hears voices, and he, I think, has a difficult time kind of making sense of where those voices are coming from, and so he does a lot of yelling and screaming and banging and throwing things in his room. Fortunately, that's improved since treating his psychosis. And people with anxiety disorders, if they're very anxious about something and have a difficult time articulating that, letting people know how they feel, if they have a panic attack, that could result in some challenging behavior. All right, so for Scooter, the patient, in terms of the etiology of his challenging behavior, he has autism, and very clear diagnosis of autism, and as we discussed before, autism, the combination of autism and ID has high rates of challenging behavior, so I think that that is part of the cause of his behavior. I also think he has PTSD. He was most likely abused by his stepfather, and there's thoughts that this occurred. His stepfather was a farmer, and there's thoughts that this occurred in the fall because of the farming season, and his challenging behavior is always worse in the fall and is also associated with sleep changes. So there's no way for us to confirm this for sure, but there's a strong suspicion that he has PTSD. And also has ADHD, so he's more hyperactive and impulsive. So I think all of these mental illnesses contribute to his challenging behavior. So next, going on to medical illnesses and side effects and how they can present as challenging behavior. There are a lot of studies out there that have shown that challenging behavior is secondary to undiagnosed medical conditions or side effects from medications. As we discussed earlier, our healthcare system does not do a very good job of recognizing common medical conditions. This population doesn't get a lot of preventative health care, and there's high rates of mortality and morbidity from seizures, a lot of GI disorders, poor teeth, aspiration pneumonia, etc. So these things are often missed. And as we talked earlier, a big reason for this is because those of us that are healthcare providers get very, very little education. And so what do we look for if we're worried that there's a medical condition, or we want to make sure that there's not a medical condition? One thing to really be aware of is this population has a very high pain tolerance. I've had so many parents tell me that, you know, when their child, who's an adult now, was a kid, if they broke their arm or had an accident, they acted like they weren't even in pain. And so this high pain tolerance can really confuse healthcare providers, because they think, well, if they had broken a bone, they should be in pain. But oftentimes they're not. And oftentimes the only sign of something bad going on is their loss of functioning or challenging behavior. And so some kind of common illnesses that can result in challenging behaviors. Constipation is a huge one, easy to treat and often overlooked. Unfortunately, I had a patient who actually died from a bowel obstruction. I hadn't seen him in over 6 months. He'd actually been doing really well, and the staff was concerned about him. They didn't contact me, but they kept going to quick cares because they just thought something was wrong medically. No one really looked into it, and he ended up dying from a bowel obstruction. Reflux and dental pathology, cavities, abscesses, etc. Often can present with challenging behavior, and usually you can see this behavior more around the time of eating. So it's important to find out when the behavior is occurring, because that can kind of point to what might be going on medically. Somebody's pulling on their ear, they may have an ear infection. If a patient is kind of spacing off at times, they may be having seizures. If someone has visual or hearing impairments, that can definitely result in challenging behavior. So making sure that someone has a visual or hearing exam done is really important. I recently had a patient who was having a lot of behavior. We couldn't figure out what was going on. He had made medical evaluations, and we kept sending him to provider after provider, and eventually someone said, you know, let's just get an x-ray of his facial bones, and he had fractured his mandible, and he was not complaining of pain in his face at all. So I got that. He was on pain meds, and things improved, and now he's doing great. All right, so for Scooter, for the patient, I think medical illnesses also contributed to his challenging behavior. Because he had this shunt, we really wanted to make sure that was the shunt working properly, so that's checked on a regular basis, and it is working properly, so that was not to blame. His seizures really have not been an issue since childhood, so that wasn't to blame. He has had constipation off and on, and when he was hospitalized a couple times, the constipation was a problem, and that was treated, and the behavior got better. And then reflux. He's had a lot of reflux, and the behavior got worse after eating, so that contributed to his behavior as well. He also had side effects from medications. Antipsychotic medications can cause a lot of side effects. One is called akathisia, and that's where people get a real restless feeling, and this can often result in behavior. He was on lots of medications and over-medicated when I started working with him, and so over-medications and sedation can also lead to challenging behavior. If you're having someone who has cognitive slowing, that's going to interfere with their ability to process information, which can often result in behavior. All right, so the next area you want to think about is a behavioral phenotype. So does somebody have a genetic syndrome that is predisposing them to have challenging behavior? And so there are 12 syndromes that are associated with ID that have known behavioral phenotypes. And the DMID that I was talking about earlier has a great chapter that goes through all these syndromes in a pretty concise way. And so the ones that are listed in red here are all associated with some type of challenging behavior. So it doesn't really help you treat it, but it helps you understand where it may be coming from. And one of my patients that I have had a really difficult time getting his behavior under control has Rubinstein-Tavy syndrome, and is really, I wish I could do something to help him, but I haven't been able to do a very good job there. All right, so in Scooter's case, really he's had normal genetic testing, so I don't think that this is contributing to his behavior at all. And then the last area that we want to think about is the behavioral etiology. So is there an environmental influence that's contributing to the development of the behavior? And so the providers that generally do this are psychologists or board-certified behavioral analysts, and there's a specialty called applied behavioral analysis. And so what these professionals do is they do a functional analysis or assessment that essentially they figure out what is the relationship between the behavior and the environment. And from their evaluations, they can figure out if the behavior is if the individual is exhibiting this behavior to essentially get out of something, so escaping from something. Are they engaging in this behavior to get attention? Are they engaging in this behavior to get access to things they want? Or they may do this evaluation and they can't figure out what. There is no clear association with the environment. So based on this evaluation, they develop behavioral plans with the goal to reduce behavior and improve skills. So with Scooter, he had a functional assessment done, and it was determined that he engaged in at least some behavior to gain attention from staff and to get out of things. And so when I first started working with him, when he would engage in behavior, the staff would tickle him and give him all sorts of attention and kind of joke around with him, which would continue to reinforce the behavior. So after a functional assessment and a behavioral plan, the way staff interacted with him changed. So when we think about Scooter, the cause of his challenging behavior was really multifactorial. It was because he has autism and because he has PTSD, so he has psychiatric illnesses. He also had side effects from medications. He also had medical illnesses. He is constipated and had reflux. And there was also a functional or behavioral component, and the functions were attention and escape. So it's not a clear-cut, nice and easy evaluation and treatment plan for folks with challenging behavior. It really is multifactorial. So now I'm going to talk a little bit about assessment of challenging behavior. And I'm showing the exact same slide again because the assessment is to essentially figure out these causes. And so you really need multidisciplinary involvement. You need a medicine, you need psychiatry, you need psychology, and then from there sometimes you need dental, hearing evaluations, eye examinations, etc. So multidisciplinary evaluation is essential. It's really important. Thorough interviews with the patient, the family, the caregivers, do chart reviews. Charts are often full of contradictive information and sometimes false information. So knowing what's out there and gaining collateral information, doing a really good physical physical exam is important. Looking in the ears, making sure there's no hemorrhoids. I mean, checking out every nook and cranny to make sure there's not something medical going on. Reviewing the medications closely and evaluating for side effects from medications, and doing a functional assessment or analysis. And they really kind of sort out the behavior and figure out what happened before the behavior and what happened after the behavior, and that helps them determine the function. And so to treat challenging behavior, you have to treat each cause of the behavior. And so in Scooter's case, he has a pretty comprehensive treatment plan, and it's working quite well, and his behavior's been under great control, and I see him every 6 months now, and he's doing great. So he's actually on Clozaril, which is a pretty big gun in the psychiatric world, but he was on tons of medications before that did not work, and we found that this worked really well, and Haldol and Trazodone. And we've tried to minimize medications as much as we can. I'm a big believer in less is more, but we got to a point where we could not minimize them anymore without a return of behavior. Constipation is a big issue for him, so we're always making sure that his bowel movements are regular and in contact with his primary care provider. Reflux is also an issue, so we have to be careful with his diet. He used to have a lot of side effects from medications, but we've simplified that, and he's on a little lorazepam for akathisia. That's just PRN. We don't think he has a genetic syndrome, so that's not an issue here. And then he also has behavioral intervention. So his treatment plan is comprehensive and covers each contributing factor of challenging behavior. And so what happens if you just don't know what the etiology is? And I have quite a few patients where we do this multidisciplinary evaluation and we have some hypothesis, but we're just really not sure. And so if you have challenging behavior that is really endangering the patient or others, what do you do? And we don't have great answers to that, but we do have some guidelines in terms of medications. These are their expert consensus guidelines. And antipsychotics are considered first line for very severe challenging behavior, followed by mood stabilizers, and then we have some second line, some antidepressants or naltrexone. I personally don't like to use antipsychotics unless I really have to. I think sometimes they cause more harm than good. I personally like to use Trazodone. There's absolutely no data on it whatsoever, but it's a benign medication. It doesn't have a lot of side effects, and I found that it's pretty helpful in treating challenging behavior. But again, I want to reiterate that none of these things should be used unless a thorough evaluation is done and you really can't figure out what the underlying cause is. All right, so in summary, this is the slide that I've showed 1,000 times, but this is when I have medical students that work with me, this is the only thing I want them to remember, that challenging behavior is like a fever, and you have to figure out what the underlying cause is, and you can't even talk about how to treat it until you have done a comprehensive evaluation to figure out what may be contributing to the behavior. So that is it. I have, if anybody has not seen this movie, I would encourage you to check it out. It's a documentary about a young man who grew up in Iowa, and his family is, well, they're all pretty darn funny, but it's also pretty devastating as well. But it's a good movie to watch. So that is it, and I'm not quite sure how the question part works, but I'll figure it out. Thank you very much.
Basically, if anyone at this point would like to write in a question, I have the question box open at Dr. Tate. I don't know, if you can't find it, that's fine. Usually I just read them off. So far,
okay. All right.
We don't have any questions. A lot of what you said resonated with me, though. It was very interesting. Growing up with my youngest sister having intellectual disabilities, there was one point where she broke her collarbone at school, and none of us knew for a week. She was at school in a summer camp, and we brought her to the beach, and I said, "Dad, look at, every time I raise Caitlin's arm, she makes this really funny face." So we ended up getting her X-ray, and
Gosh.
we're like, oh yeah, it's a broken collarbone,
Yeah.
just because her pain
Yeah, it's so
tolerance was so
true.
high. All right, here's a question. This question asks, can you describe how your inpatient MI clinic functions and how it was started?
Sure. So I've worked with this population for about 15 years and recently frustrated with our system or lack thereof of how to provide these multidisciplinary, interdisciplinary evaluations. And this patient population would come to our inpatient unit and not get great care and end up being there for very, very long periods of time. So we put together a business proposal, and essentially I said, you know what, if we actually provided interdisciplinary care, then I think we would have better outcomes and decrease the length of stay. And so for those of you that are in the medical world, you realize that, you know, long lengths of stay are not good because it doesn't equal money. And also insurance companies were not paying for they were essentially denying the hospital stay. So the hospital was losing a lot of money. So we developed this business plan that entailed hiring a psychologist to do the ABA evaluation, physician assistants to work with me to do the psychiatric and medical evaluation, and an assistant to help our psychologist. And we got it. We hired those individuals, and so our program consists of a 4-bed inpatient unit, and so we provide this comprehensive evaluation that I was talking about for this population, and then we also look at outpatient. So it has continuity of care, both inpatient and outpatient, and we also provide education and training to community providers because many community providers, many do have the knowledge and experience, but many don't, and so it's really hard to implement these behavioral plans. So it's comprehensive care, inpatient, outpatient, and education. And we've had it, it's been going for a year now, and so far so good, and it's so great to be able to work with an actual team instead of having to, you know, track somebody down to help you.
Neat. That's great. I'm glad that worked out. Or so
far. Yeah. Yeah, so far.
A few more questions came in. Actually, yeah, 4 more questions came in. The next one is, do you have any experience with dementia and ID with regards to CB?
Oh, yeah. Dementia and ID. So I'm gaining more experience because my patients are aging, and I actually had my first patient who had Down syndrome and dementia died. Hello? Can you hear me?
Yep. I can hear you.
And so I have a little experience. Excuse me?
You're still there.
Oh, okay, okay. So essentially what I have not been using the Namenda Aricept medications. I've tried them a few times. People have side effects on them, so I've chosen not to use them. Tried to just treat the behavior with PRN trazodone and really try to get the environmental supports in place to help the individuals maintain independence and community living as long as possible.
All right, thanks for that. Our next question asks, have you seen specific behaviors associated with specific body system issues, such as GI or respiratory?
Lots with GI. So constipation is huge. Reflux is huge. A lot of, a good way to pick up reflux problems are if there's drooling around mealtime, or if there's challenging behavior around mealtime. And then sometimes just a trial of a PPI is warranted. With constipation, I usually get abdominal films to evaluate the stool burden. It's oftentimes really difficult to get a good history from direct care providers and bowel movements because, number one, they just might not see it, and number two, it's hard to document it. So constipation is huge. We usually test for H. pylori as well, and celiac disease, but I've seen a lot of behavior resolve once constipation is treated appropriately.
You might even have an advantage in some of the patients that are still using diapers because it's one way you can track it.
Well, you can track it, right. But oftentimes people say, oh yeah, well they are having bowel movements every day, but they're really tiny little, pellets. Or sometimes people are like, oh yeah, they're having lots of, it's all runny. But sometimes people can get overflow incontinence, so they're really constipated, but the stool comes out around the, bolus of poop. And so it seems like they have diarrhea, but they really don't. They're having overflow incontinence. So I spent a lot of time talking about poop.
I think that's medicine, though.
That's right.
The next one is, do you have any tips on how to distinguish akathisia from increased behavior in a person who would be unable to describe a sensation?
Yeah, so, well, first of all, the medications they're on, and if there's been any recent changes. So if the timeline fits, if somebody started an antipsychotic and then they're more agitated, but generally that's not the case. They're started on an antipsychotic because they're agitated. But the type of behavior someone's having, if they're pacing a lot, or if they're moving their legs a lot, or if they're unable to sit still, those are some hints that it could be akathisia. Sometimes it is just really difficult to tell, and if I have a high suspicion of it and I really feel like they need to be on the antipsychotic, I'll just treat it with sometimes low-dose lorazepam or benztropine, but those medications have bad side effects because they can cause cognitive slowing, and benztropine can cause constipation, so it's always this balancing act of, how strongly I think that that's a contributing factor. I usually try to just get the antipsychotic down or off if I think that's a contributing factor. The first thing we usually do when people come inpatient is we try to clean up their meds as much as possible, and oftentimes people get a lot better just being on less meds.
Great. Okay, we have two more. The next one is, with a push for integration of individuals with IDD into the community that encourages them to access community providers and quick care clinics, how would you advise both direct support professionals and community providers to manage patients with these complex healthcare needs?
Do not go to quick care clinics. I think getting a primary care provider and having regular appointments with that primary care provider, I would avoid quick care clinics unless you want to test somebody for strep throat or something, because the lack of continuity of care is challenging for anybody, but with this population it's even more challenging. So advocate for getting one primary care provider and stick with them, or at least stick with that clinic, that same clinic.
So that's pretty straightforward. So that's a good
Yeah.
All right. And our last question is what your thoughts are on sociological lens on challenging behavior, living condition, lack of inclusion, and quality of life. Yes, hold on one second. At best, 25% of a population exhibiting challenging behavior suggests a need to look at systemic factors and solutions in conjunction with other things you've discussed.
Absolutely, and I should have said that that's not an all-inclusive schematic, and there's many other things that contribute to it. I think in terms of what I feel like I can do as a physician, those are the things I look at. But absolutely, there's so many societal factors that are also involved. And I also didn't talk about skill sets and choice, and so I agree.
Right. Very complex.
Very complex. There's no easy one answer.
Right. All right. Well, with that, we don't have any more questions. So I'd like to thank presenter Dr. Jodi Tate so much for taking the time to come and share your knowledge with us. I think I speak for everyone when I say you put on a great presentation. And other than that, I hope everyone has a great night.
Thank you.
All right. Thank you.
Good night. All right. Thanks. Bye-bye.
Bye-bye.